συνεχίσει ο Νίκος πιο συγκεκριμένα. Okay, I think it's time to get started with today's webinar. And I would like to welcome all of you, both the excellent speakers and the audience, to this fruitful meeting. If I remember well, this is the second webinar for this year, which belongs to the fifth cycle, educational cycle of the Hellenic Group of Sarcoma and Rare Cancers. Today's theme overall is the artificial intelligence in cancer management. And at this time point, I would like to pass the microphone to Nikos Vassos in order to make the introduction for the first speaker of our webinar.
So, thanks, George. Good afternoon, everybody. I would like, from my side, to welcome everybody who is joining our webinar today with a very interesting topic, as Professor Agrogiannis already mentioned. Artificial intelligence is no longer a promise for the future. It's actually part of our present, transforming the landscape of diagnosis, prognosis, and therapeutic approaches, especially for oncological patients. So I'm really glad then to introduce the first speaker, who is above all a very good friend, but an excellent neuroradiologist, is Professor Bizdas, Sotirios Bizdas, which is a consultant neuroradiologist at the University College of London, associate professor at the University College of London, and professor of neuroradiology in the University of Tübingen, with a long-term experience in neuroradiology and radiology, special for oncology patients, and very up-to-date regarding AI. So, Sotirios, we're really glad to have you with us today, and we're looking forward to your talk. Thank you so much for that.
Really, a big thank you from my side as well to the organizing committee and to you personally for this kind invitation. So today I will not speak generally about AI in a theoretical manner. I will just try to show you how AI is already, as you said, part of the present and creates value for the cancer patients and causes tangible improvements in patient by better cancer diagnosis and prognosis. These are my disclosures, which are not relevant to today's talk. Now, let's think that AI is a different way of thinking in cancer imaging or in medicine in total. The traditional way so far has been the so-called hypothesis-driven research. So everybody of us formulates a hypothesis, collects data, through analysis and interpretation, tries to find new biomarker and then clinically validate that in a clinical trial and end up with a conclusion or end up with a treatment. However, this way has proven to be a little bit difficult with many hurdles. First, the testing of each imaging biomarker for cancer is time-consuming and expensive. Just think of the clinical trials associated with that. And at the same time, we are not using the full potential of the images. Images are not like pictures only. They are a phenotype of the underlying condition. And there is a lot of information in the images that cannot be perceived or used by the human eye, but it needs a computer-driven approach. So from this hypothesis-driven research, today, with the help of AI, we are moving towards the data-driven research. We are using the data, which is already in our silos, in your hospital, but also the prospectively acquired data. And after some curation of the data through technical qualification tools, we start to generate hypotheses based on the data patterns, and new candidate biomarkers that you may even not, we didn't even know about them, emerge out of the data, and they are clinically validated and they lead us to new treatments. So AI presents an unprecedented opportunity to advance our understanding of cancer and help our patients. There are many AI applications across the spectrum of cancer research, but The main pillars of AI in cancer research are the tumorigenesis, the cancer screening and diagnosis, the drug discovery, cancer surveillance, and healthcare delivery. So I will not, of course, go into each of it, and I will just touch the surface talking about the cancer biologies and tumorigenesis, where instead of the simulation models and this, all the analytical approaches that are used in order to find new treatments, today's AI, if this is a synonym for you for ChatGPT, is used to improve knowledge extraction from research publications and then use AI models to simulate, for example, the atomic behavior of the RAS protein, and also to find all these, to elucidate probably all these metabolic and tumorigenesis pathways downstream. We will now focus mostly on how we can use imaging, AI-assisted imaging, to expedite cancer screening, detection, and diagnosis. First of all, we have tangible evidence from literature that AI is helping to improve the speed, the accuracy, and the reliability of screening. And you will see that in a minute. There are many paradigms from our daily life in cervical, prostate, or breast cancer. At the same time, there is already FDA-approved AI-based software for pathologists to identify areas of biopsy images that may contain cancer or that might be procancerous. So today's pathology is hugely AI-driven. And of course, this actually exploits the AI ability to identify patterns in images. And at the same time, actually, it is a mitigation of the risk for human eye errors. And at the same time, research has shown that AI imaging algorithms, for example, not only improve the breast cancer detection on mammography, let's take this as an example, but also can help predict the long-term risk of invasive cancers like the breast. Let's dive a little bit more into the breast cancer screening paradigm. There are many ways to use AI as a human assistant in the breast screening setting. I have here highlighted 4 of them. It's the standard double reading, which is the gold standard. But now let's replace the second reader with AI, or let's have the third reader and have AI as an assistant to the third reader. Or we make it move the AI as an assistant to the second and the third reader, or have a 3-layer reading. So many ways, many combinations where AI can leave its tangible footprint in the pathway of breast cancer screening. And this is not just theory or that's just simulation numbers. There are real numbers. The AI enhances the early breast cancer detection up to 98% accuracy, which is an extraordinary high number. Of course, if you have more images, if you train your algorithm in dozens of thousands of images or hundreds of thousands of images, then you move from the domain of machine learning into the deep learning. And the deep learning has equal, more or less, performance like the most experienced human. So this is not the only thing. At the same time, the AI is not just giving you a detection rate in a binary way, yes or no. It gives you the so-called heat maps. And the heat maps give you probabilities. The red is the probability of 98% or 95% cancer. But at the same time, you have gradients of the red. You see areas of possible peritumor infiltrations, as you see here in these images. So this is not, again, something that is wishful thinking or that are single institution results that can be hardly replicated in the real life. The first randomized controlled trial in AI is now already done. And in 80,000 women, we randomly, who underwent breast cancer screening. There was a random assignment to AI-supported screening or double reading without AI. So I will not go into details about this study, which was published in New England Journal of Medicine, but the AI-supported screening had a cancer detection rate of 6.1 per 1,000 participants compared to the humans, which was 5.1. At some point here, we cannot even claim that the humans are better than the AI, but we can always use terminology like non-inferior to humans, because we may, as humans, be wrong in many cases. Beyond that, the AI reduced the screen reading workload by 44%, which is really something tangible and important. And the AI-supported mammography had the same detection rate as the standard double reading, which is time and resources consuming. So now I just gave you a brief look of how we can use AI in cancer screening, but let's see more real-life applications. The good thing with MRI is that it has many weightings, as you know, many sequences, and each sequence has unique features that can be read in a meticulous manner by computer vision algorithms, and these computer vision algorithms are the backbone of AI. So, plenty of information. Now, let's go to the next step, the segmentation, the cancer segmentation. Either we are talking about brain cancer, which is very challenging to segment and set the boundaries of the cancer bulk, the peritumoral infiltration or the edema. We can talk about prostate, about breast, about hepatic cancer, and pancreatic cancer, anything. The next application is feature extraction. So the pixel, the value, the gray level value that each pixel has more value than just a number. It is a phenotype of the underlying genotype, and I will give you more details in a second. So out of these gray level variations, we know which are the most aggressive tumor parts or not. So we extract features and we can represent them even in 3D volumes, which are very useful for surgical resection. And these features feed the prediction models, where using techniques like support vector machine or deep learning, we can give indicators of the overall survival, of the progression-free survival, and so on. The last step in this puzzle is to use these values, the imaging values from the MRI or from advanced MRI techniques or PET, in order to link this with certain genotype constellations. So let's start with a tumor segmentation. Why is that important? It's not important only because tomorrow morning I can give a value, a volume of the tumor to my dearest friend, Nikos, and say that it is 3 cubic centimeter what you need to resect. I can also give the volume within the longitudinal follow-up of these patients. So it is much better than measuring by dimensional dimensions, by measuring in a bidimensional way. It is just a more accurate representation of the tumor behavior. It is also very important for the clinical trials. So either if we are talking about RECIST or MRANO for brain tumors, the software determines the optimal combination of the slices or orientation of the slices in order to measure the tumor longitudinally and eliminates the human error in the clinical trials. So the tumor segmentation can be done either in a semi-automatic or automatic ways, can be human supervised or can be completely unsupervised using the newest algorithms. Having this information now, we can follow up the tumor perfectly and just not follow the boundaries of the tumor, but we will know by combining many weightings and many MRI modalities or PET, which are the increasing parts in the tumor, both in terms of volume or in being more aggressive and with the ones that are stable under radiotherapy or chemotherapy. At the same time, we can predict during radiotherapy or chemotherapy which parts of the tumor will grow and which are less susceptible to growth, which are the blue areas that contain probably tumor, where the tumor microenvironment responds to therapy and which one is not responding. This prognostication is very important because it works in a so-called agnostic manner. So we have the so-called unsupervised machine learning methods in radiomics. These unsupervised learning methods rely on deep learning, pattern recognition. So we don't start with a hypothesis that the contrast enhancing part of the tumor is the most aggressive or bears the potential for future growth. Everything is agnostic. We feed the images to the tumor, to the data, to the algorithm, sorry, and we call them, we ask them, having this wealth of information, can you identify the areas that didn't respond well or they were actually predestined to grow very quickly? And the new features, the new areas, they might not be the ones that we thought. So we are now working in uncharted waters. So we discovering new things. And one of these new things is the so-called habitat, the tumor habitat, which is something very popular now in neuro-oncology, is the tumor region which is characterized by distinct imaging features, which actually they are not dictated by the genotyping or by what we know so far by the current knowledge, are actually dominated from intrinsic cell populations or local environmental conditions which have a straightforward representation in the radiology, let's say, domain. And here it is about radiogenomics. So, as I said before, there is a link between the radiological features and the genomics. The wealth of information is huge. This is why we call it big data. The information that we get from an MRI combined with all the underlying genomic information are hundreds of gigabytes. So we need AI to go through that because it is impossible by simple mathematical representations. The radiogenomics belongs to the overall omics family of techniques and methodology like metabolomics and so on. So it is a better understanding of the imaging representations of various molecular phenotypes. For example, I will give you a just very crude example is that areas of enhancement in the glioblastoma, they have higher expression of EGFR, or the areas of edema where there is a so-called mismatch with T1 and T2 weighted images, there are the carriers, these areas of IDH mutation. So by combining all this big data of the called omics data, and we call it now multi-omics, together with the clinical data and even more advanced omics like the spatial transcriptomics, we end up with a deep learning technique, a deep learning algorithm, which has been fed with multimodal data. And the output is the improved diagnostic accuracy, the personalized treatment, or the better understanding of tumor biology, which will inform better treatments. So it is not something which is utopic. Of course, it is not probably your daily life, and you don't see that in your daily routine, but the first attempts there have been very fruitful. So one of the first attempts was in the area of pancreatic cancer. So this is a very nice paper published in Nature Medicine 2 years ago. It was based on the Danish screening database for pancreatic cancer. It was cross-validated with the respective corresponding US database, and we should keep that here as a very important message. The cross-validation with other hospitals, with other institutions, with other countries is actually the crowning of the validity of the technique. So briefly said, in this paper, they followed the disease trajectory using AI from the screening to the treatment. And always they could derive new biomarkers using AI techniques, either very advanced or less advanced at the screening phase. So they could follow the disease trajectory. They could, these 4 phases, they could, first of all, pick up the cases which needed immediate treatment or the ones that were followed up. They assess the risk for the treatment having a good prognosis or not. They personalize the treatment, even at a very crude level of high risk, low risk, or medium risk. And then they even predicted the progression-free survival and the overall survival. So far I have shown you, let's say, the bright side of the moon. Now, I don't have any dark side to show you, but I ought to remind you of key things that should be considered if we envision this AI to dominate the cancer care. The first is generalizability. The AI that is produced in London should be generalizable enough in order to be adapted, if not adopted, at least adapted in the United States or in Athens. The second thing is the interpretability. Machine learning and deep learning and AI should not work like a black box. What is the output should make sense to us as cancer experts. And of course, the output should be reliable. This is not something that it is gained immediately, but through exhaustive validation. And this prospective validation in a good setting, in a good hospital setting, is needed. Again, I would stress again the generalizability, the transparency that AI needs to have, the traceability, the fairness. We should not forget about fairness. The AI models should not be trained and created only for particular population, subpopulations, or population groups. AI should be democratized and actually belongs to everybody. It is very unfair when we train AI for the prosperous and the Western Hemisphere societies. So a model shall be developed in a way to be inclusive for everybody. The last thing is the explainability. And explainability in AI is a very important trend. This is why we call it sometimes XAI from the explainability. And we need explainability because we are the users of AI. We need to understand it. We should not be dictated to do things when we don't understand it or when they don't make sense sometimes with a conventional medicine. So, to sum up, I think that I provided you some tangible evidence that in the domain of cancer screening, AI can expedite it seriously. It can improve the accuracy in cancer detection using multimodal imaging, and combining this multimodal information in a unique manner can offer comprehensive tumor staging. And this is real life in brain cancer, where now we can talk about using the radiology images. We can talk about the IDH mutation or the MGMT methylation and so on. We can optimize the tumor surveillance by looking at each part of the tumor, how it will behave and whether it has responded so far. And this is the foundation for prognostication. And at a later stage, at a future stage, but a near future stage, this will be part of the multi-omics and the multi-domain cancer care models, where we will take advantage of all this information from imaging, pathology, transcriptomics, metabolomics, plus the clinical information from the electronic health records for a better understanding of the cancer trajectory. Thank you very much.
So thank you, Sotiris, for this really amazing talk. It seems that, as I already told, this AI is already here as a part of our present. And I think that you did present it actually in a very amazing way, actually, how AI can be established in radiology. I don't know if anybody of our audience has any question for Professor Bizdas or on chat, maybe.
There is a question actually from Evangelia.
Okay, yeah. Okay, so Evangelia Karasteriou. Thank you, Professor Bizdas, for the excellent presentation. How far are we from completely relying in radiogenomics in order to decide as oncologists whether we can give a target therapy to our patient or not?
Yeah, great question, because it is a very practical question. Unfortunately, I cannot give you paradigms for each cancer type. I can, as a part of the neuro-oncology team, I can definitely tell you that today the radiogenomics in neuroradiology are so very good in order to confirm without invasive biopsy that the tumor bears an IDH mutation or the medulloblastoma is of the certain type, what it is. So you don't need it. The accuracy is, or the sensitivity is 100%, the specificity is about 95, 96%, which is not bad. We should not think only about 100. Even the pathologist, the invasive biopsy bears a risk of indeterminate findings. I know from my colleagues that more or less the same applies to breast cancer. So, and I'm not sure about the prostate cancer because there is not really a lot of genomic information that is needed for the treatment of prostate cancer. But it is a matter of time. At least two, as I mentioned, two cancer types are, we are very far with the radiogenomics.
Thank you.
Okay.
Are there any other questions from the audience? Because I do have one for you, Sotiris. You talked about fairness and explainability and reliability of AI in radiology. And I would like to ask you, do you think that, or how can we actually ensure that AI tools in radiology are fair and unbiased across diverse patient populations? And in these terms, because there is a lot of clinical skepticism about that, if you allow me a second sub-question, what are the barriers to adoption of AI in radiology departments? How can we overcome, at the end of the day, the clinical skepticism?
Yes, thank you for the question, because again, it's a question that touches the real life pains. So in radiology, we work with AI since more or less since 2019. So the radiology community is quite mature in terms of AI. And 2 years ago, we agreed on, or we set out an initiative about fairness and transparency in radiology AI programs. And we agreed on having a checklist. So every AI program in radiology has to go through each item of the checklist, and each of this item promotes transparency and fairness. Just to give you an example. So each AI program each company should disclose the training sample which was the makeup of the training sample, how many white British people they had, how many Black British people they had, how many Asians, how many, and so on. So it has to give exact percentages of the training. It has to disclose also the validation sites, which were disvalidated. Also in terms of subjects, how many thousands of the first set, how many thousands of the second group. The third is to disclose to the degree that is possible, because a lot of it is protected by intellectual property laws, which are the algorithms that were used in order to build the overall program, and so on. So we are, and the last thing is these so-called heat maps that I showed you in the breast cancer, or they are called in AI language attention maps. So it is not about here spitting out a diagnosis, cancer or not cancer. It has to show us where it did find the cancer. And we ought, as radiologists, to double check, is this plausible? So the heat maps or the attention maps was a great step in fairness and in explainability. Now, of course, there are many barriers, as coming to your second question, there are many barriers when it comes from the bedside to the, or from the lab to the bedside.
The bedside, yeah.
So, and one of the barriers is how, let's say, how trustworthy is AI, which in my eyes has matured and it is trustworthy in many applications. Now, the acceptance across radiologists, we need to educate them. They are not well educated, but we don't need to educate them by telling them they have to consider AI. We have to educate them by explaining them what is AI, to make them a judge of the AI and not a blind adopter of AI. And the third barrier is the financial barrier. Unfortunately, in many countries in Europe, AI-assisted radiology is not reimbursed. Officially reimbursed is only in Australia and the United States. This is why really AI flourishes in radiology. Here in Europe is used at our own costs by big university centers, big research centers, and so on. If this was kind of reimbursed, then we would see more and more penetrance of AI as an assistant to the daily life of the oncologist, of the radiologist, and of the medical expert in general. So initiatives like this one from the European Commission, for example, are very important. It started in 2022. Now it has hundreds of thousands of patients, and it raises the awareness among oncologists, among radiologists, that they need to rely on AI in order to promote cancer care and to offer better cancer care.
Great. So thank you so much, Sotiris.
Thank you very much. It was great
for your great talk. It was really an honor to have you with us today. It was amazing. Thank you a lot. I think we should actually proceed with the next talk. Stefania.
Okay. Good evening, everybody. I would like to present the next speaker, Nicolas Coudray, who is an image analysis specialist and a senior scientist in Aristoteles Chirigo's lab, Applied Bioinformatics Laboratories in New York, NYU Grossman School of Medicine. The research focuses on revolutionizing the understanding, the diagnosis, and treatment of diseases through big data and advanced machine learning methods. So, Nicolas.
Hi, hey everyone. Let me share my slides. You hear me, right?
Yes, we can hear you. You can start sharing. We are looking forward to to your talk about decoding clinical outcomes with interpretable unsupervised machine learning.
Hi, hello everyone. I'm part of NYU, and we have our mission is as a hospital as well is to improve patient care by harnessing emerging technologies, especially using multimodal dataset and AI. And we have a bunch of projects which imply clinical history, medical imaging, multiomics, mobile health. And we are slowly moving forward the use also of self-supervised machine learning. We're targeting a bunch of different cancer types. But I think since the group here today is focused on rare cancer, I wanted to talk about one of our project, which is on rare cancer, which is the one based on osteosarcoma. And this is kind of the overview of this pilot study on this rare cancer and the strategy that we adapt. So as you probably know better than me, osteosarcoma is a rare primary malignant bone tumor with a poor 5-year survival. And the current strategy is to quantify the necrosis within the tumor following neoadjuvant chemotherapy. And it's been shown that the necrosis to tumor ratio has been somehow associated with the treatment response of the patient. So our cohort is quite small, naturally because it's difficult to find cases. So as part of NYU, we had 42 patients, fortunately a large number of slides, so 225, which were used for the AI. And we had some external data set also made of 12 patients, amounting to 100 slides from Prague University. So on the right-hand side, you can see the strategy that we adopted. And basically, it's centered around three questions. So as mentioned, so the tumor to necrosis ratio is currently used. So the first question was can AI be used as a simple task to just identify the necrosis on the tumor, basically to alleviate the inter-observer variability that you can have when one user versus another try to quantify what this ratio is. So if it's automated, then it's more likely to be reproducible and less variable between different people. So that was the first question. And then once we have this question is well, let's go one step further. And instead of just seeing if the ratio is predictive of the treatment response or the survival, is there anything within the tumor or within the necrosis region that actually has some prediction power, or is there any biomarker that can also be used as a survival prediction? And all of these first two steps were done using supervised approach. So the last question that we wanted to use is let's use state-of-the-art unsupervised approach and how this unsupervised approach can be used to identify morphological patterns which are associated with poor outcome. So I'm going to go through these three steps. And so the first one is the tumor necrosis ratio in osteosarcoma. So as mentioned, it's been reported as a likely prognostic factor, but there's an inter-observer variability in quantifying that ratio, and we want to use AI to achieve that. So this is a simple task in itself. If you have large amount of slides and they are annotated, which was the case in ours, and this is the pipeline we used. So usually in these large whole slide images, because they're really big, what happens is that usually after splitting them into the train, test, and validation set, you usually tie them in really smaller regions. And basically these are the regions which are fed into the neural network and where each of these regions and small tile have a label. And this is what is used to train the algorithm. So what we have, basically we have a pathologies which have annotated the slides. And then before tiling, and then once they're tiled, we know for each tile basically whether they belong to a tumor region, a necrosis region, or to some other normal tissue. And on the left-hand side, so you have an example of the segmentation achieved by the AI. So on the first column, you see the original images, and the second column, it's the segmentation achieved by the algorithm, by the supervised approach. In red, you have the tumor. In orange, you have the necrosis region. And in blue, you have the other types of tissues. And in black is just the artifacts. So you can see, for example, if you have some pen markers, it's just pretty good at identifying that it's an artifact and just not include it in the analysis. And in the second column, so we just have basically using these images generated by the AI, we do a comparison of the segmentation and the ratio necrosis to tumor achieved by the pathologist versus the one achieved by the AI. And although there are some variabilities, which is expected, you can see that the R-square value is quite nice. And it can quite well reproduce what the pathologist does. And then on the last column is basically the task and the reason why this ratio is computed. It's to achieve the survival plot. And here's the same. So we just compare what the survival plot would be on these 42 patients if we were to use the pathologist annotation of the tumor to necrosis to tumor ratio and what it would be if we use the AI. So you have the AI results on the top and the pathologist one at the bottom. And you can see that basically the results are pretty much the same. And in both cases, in our cohort at least, so the C-index is, although the C-index is quite low, it's not random, but it's overall quite low, showing that for at least our cohort, the tumor to necrosis ratio seems to have maybe some kind of prognostic factor, but kind of very weak. But in any case, the necrosis tumor ratio via the supervised approach kind of simulates the results and the conclusion that would have been drawn if we were to use the pathologist annotations. So that's the first step. So it's how like a supervised and algorithm can be used to like segment an image, and then how can be used to go one step further, and on a small cohort see if basically the intranecrosis or intra-tumor features themselves are relevant to survival prediction. So the strategy was to train a separate network to classify patients just versus good and bad outcomes. So just two classes. And this done on the three types of tissues which were identified. So basically we took the tumor region only and we say fed it to the algorithm and say, okay, are you able to differentiate those with good and bad prognosis? And we did the same with the necrosis and with the same with like the normal other tissues. So the normal other tissues kind of can be considered as a control. And for the control, which is in the first column here, basically there was it was not able to classify the patients according to the outcome. So basically the normal tissue doesn't contain any information or any differences that allow us to differentiate the two groups, unsurprisingly. However, for the necrosis and the tumor themselves, the separation was able to some degree separate the two groups. So for example, if we take only the necrosis region, you can see on the left-hand side here that with the survival plot, there's kind of a nice separation between the patients who have a good survival versus those who have a poor survival. And if we look a bit closer to what features were used, so on the right-hand side, so like in the previous talk, we use like a heat map to kind of see which tiles were actually used by the AI and try to understand why it made these decisions. And see which regions were actually labeled as having poor prognosis and which regions were highlighted as having good prognosis values. And here you can see some examples for the necrosis on the left-hand side, which were predicted as detrimental to the outcome, and here the kind of features which were predicted as not detrimental. And although more necrosis is usually associated with better prognosis, we can see now with this study that areas with lamellar bone, fat necrosis, and necrosis cartilage seem somehow to lead to worse prognosis. And the same for the tumor region. It looks like in the tumor regions as well, there are some different features which are present in the patients who survive versus those who have worse survival. And here again, you see an example with this case 5150 on the right-hand side. And you can see the tumor with the kind of features here and the kind of tumor which are kind of detrimental to the outcome versus those which are not. And basically, the conclusion for this one is that like the viable tumor with solid epithelioid morphologies and those lacking lacy bone formation generally generate better outcome than the other type of tumors. So basically, from this second step, the main conclusion is that the heterogeneity within the tumor and within the tumor beds themselves can also be used for overall survival prediction. So when you do this kind of supervised approach and supervised learning, you basically need a label, annotations, and when you train the algorithm, you have to already tell him what you train it for. So basically here we just assumed that tumor regions may have some prognosis value, so we train specifically for these tumor regions. The supervised approach has their limitation, and that's why in the lab we've developed some self-supervised and investigated the self-supervised approaches. So also the supervised approaches these are part of the limitations. So large amount of data required expert labeling, especially for the segmentation if you want to learn segmentation. It's tedious, time-consuming, extremely costly. And basically, you just can't do anything without any label or annotations. And I'm just going to take a step back and just present you before going further the self-supervised learning strategies that we've developed. And it was developed and published last year. It was developed on lung cancer. And I'm just going to take a step back and go to lung cancer to show you what we've done, how we've developed it for lung cancer. So the self-supervised architecture, the advantage is they can automatically learn pattern in large collection of images without you specifying and giving any label or annotations. And they automatically generate features, textures, shapes, and they automatically learn what the features, texture, or shapes are and how they are present in the images you give them. And then you translate those features in a vector, in our case, with 128 cells vector, that can be considered as a barcode, the barcode of the image, which you can use further down the road to do some classification tasks or prediction tasks. So basically, you use that barcode and see to analyze the images. So the pre-processing is pretty much the same. So once you have whole slide images, we tile it into smaller images. That's example how a tile looks like at 40x. And then we want to generate the embeddings for each tile separately. The architecture that we've been using, it's called the Barlow twin architectures, which were developed like 4 years ago already. And it automatically generates features given two constraints. One is the invariance to distortion, and the second one is the redundancy reduction. So as you can see at the bottom, basically the idea is like you have a twin network and you feed the two networks with the same image, except that it will be the images will be distorted in one of the networks. So the distortion that you apply at the input will be kind of different. So basically the network will learn that the two images distorted in different ways are actually representing the same type of information. And after several rounds of learning, so that's how basically it should learn to recognize the features and the images on the neural network in a very kind of basic level explanation. So then for each tile, once it's learned, for each tile you have, as I said, kind of a barcode or embedding, which is called a vector representation. And if you plot them each tile on a UMAP for the lung cancer, that's how it looks like. So we applied it to 1 million tiles from about 500 lung adenocarcinoma patients. And we applied a reduction to plot the map in this kind of 2D representation for better visualization. And as I say, in this map, each dot represents a single tile. And the idea is like now, if it were trained properly, then all the tiles which share the same kind of features should be located should have a very similar barcode and therefore should be located in very similar regions on this UMAP. And it's exactly what we observe. So it's like on the left-hand side, for example, all the tiles that were present on the left-hand side correspond to malignant features. And on the right-hand side, all the tiles showed kind of benign features and morphologies like airways, cartilage, connective tissue, and other vessels and other type of things. Also, what we observed is like if we use another network to just automatically annotate the cells on the tiles, we also observe that the cells present in the different tiles, there's also some kind of homogeneity, like all those on the left-hand side contain like neoplastic cells as expected, but you can see also that like here there's a certain number of regions which are enriched in inflammation. So that just shows us that the self-supervised network has indeed learned to recognize different consistent morphologies and assign them like barcodes which are close to each other and similar to each other. Looking at the different type of patterns now, we can see that there's also grouped in a very coherent and meaningful way. And what we do usually when we have this UMAP, so we do some kind of clustering with the Leiden clustering algorithm. And then once we have here, we have like about 40 clusters. And for each cluster, we just pick randomly like 100 tiles, which we show to the pathologists for them to annotate and see and tell them, okay, what do we have here in this cluster? And you notice, for example, here that all the tiles in these clusters here on the top left are actually associated with the solid pattern of adenocarcinoma. And then you can see in the different regions, you have kind of a different type of pattern. So you have tiles representing acinar pattern, you have the cribiform pattern, the lipidic pattern here, and the papillary and microbari. So all the subtypes of the lung adenocarcinoma are present and clustered in meaningful ways here. So again, the advantage of such method again is that when you train it, you don't have labels, but also here you can see that you have interpretation and explainability, which is important as mentioned in the previous talk. And the thing is that now that we have like these clusters and these kind of 46 these distinct patterns, what we can do now, we can analyze whether these patterns and these what we call HPC, so histomorphological phenotypes clusters, are associated with any survivals or any kind of task that you want to perform now. And the idea is like now when you project those tiles and those clusters on the images, again, which is nice, like you have kind of segmentation, even though you don't have any annotations or manual annotations. So you can see here it's consistently assigned cluster 42, which is the cartilage, to the cartilage region here. You have all the solid pattern on the right side, which is meaningful. And what does it mean? It means that now the tile of each patient can be described as a composition of HPC. What percentage of solid pattern you have, what percentage of cartilage, and so on. And then once you have these percentages and this composition, you can see is the composition predictive of any survival. And when we did this Cox regression on those HPC and those clusters, you can see on the top left that we have a very nice separation for the NYU cohort between the patients who have good survival and those who have poor survival. And what is the advantage also of this is, again, as I said, is the explainability, because now you will know what HPC are users are important to do and to do this kind of prediction. On the top left, you have an example for one patient, for example. So this is a SHAP plot. On the x-axis, you have the different histomorphological cluster. And you can see here the curve is like, if it goes up, it's like bad prognosis. If it goes down, it's good prognosis. And it also sorts them according to what are the features and the morphologies that were important to make this decision. And here you can see that basically the prediction of poor prognosis for this patient was basically because these three kind of morphologies associated with HPC 15, 5, and 11 were kind of enriched for this patient. And this corresponds to a solid pattern with few tumor-infiltrated lymphocytes, also solid nests with stromal teal, and some solid and crimpiform pattern. And on the right-hand side, you have kind of also example of what are the tiles with poor outcome that basically were used to make this decision. So that's basically how this method has been developed and what's the advantage. And we wanted to use it for the osteosarcoma cases. And here you have an example. So the same on the left-hand side, you see the UMAP. And if we color each tile according to the prognosis, whether it's poor prognosis or good prognosis, you can already visually see that here there's kind of enrichment in patient with good prognosis, and you see on each side enrichment in patients here with poor prognosis, where there's hardly any tile associated with good prognosis. And then you see that if we run a Cox regression on the histomorphological cluster that we've identified here, you can see also that there's a nice separation on the top right between the patients with good and those with poor survival. And then when we look at what morphologies were used to make this separation, then we observe that the HPCs, meaning the clusters and morphologies associated with worse prognosis, were enriched in fat necrosis, lacy pattern, variable osteoblastic morphologies. And those associated with better prognosis were enriched in tumor with osteoblastic and fibroblastic morphologies. So basically, those morphologies associated with the outcome kind of match and confirm what we found previously, except that in this case, so they were identified with a completely self-supervised way, in a way also which gives the pathology some explainability, which yeah, again, as mentioned, is kind of one thing which is really becoming critical as more and more approaches are developed. So that's the team that's been working on this project. So Aris, of course, was the PI of the lab. The Kiwang lab with Adar Kiros, who developed the self-supervised algorithm in Glasgow, and George, Michael Occidental, and Jose Mantilla, who've been helping with the osteosarcoma project and leading the osteosarcoma project. And Jan Balko from Charles University in Czechoslovakia, who gave us the external data set for external validation of the approach that we used. Yeah, that's it. Thank you for listening.
Thank you very, very much, Nicolas, for this very interesting presentation. I think your project on osteosarcoma is very interesting for us, working with sarcoma and osteosarcoma patients. Are there any questions from the audience? So I will start. Are you planning to continue with this project on osteosarcoma?
So for now we don't have, so we'll probably get more slides eventually. So I think now, you know, as usual, when you have like these rare cancer, the most critical thing is to get access to the data and find those data sets. So I think it's probably going to take some time. So I think the next step will just be to try to get more larger cohort to confirm the results and to move forward with this.
Do you have any experience with this kind of work, but looking to modification post-radiation therapy? In some soft tissue sarcoma, before the surgery, we deliver radiation therapy to patients, and it is really hard to tell if there is a response or not. and what is the prognosis? Do you have any experience on looking to that response post-radiation therapy in the slides?
I think this one was post-radiation, actually, if I remember.
I think it was post-chemotherapy, this
yeah,
one.
post-chemotherapy, sorry. Yeah.
Yes.
Yeah, no, we didn't for this one. No, we don't have like post-radiation, but I think it's already the pipeline would kind of be the same, would be, I mean, you can have a biopsy before and after, and you can just feed the algorithm, and then you would see kind of you could have you could have either like a prognosis, try to do some prognosis and survival analysis, but you can also do some comparison of morphologies. You can see which morphologies were enriched before and which morphologies are enriched after. So that will kind of give also some kind of ease the explainability or the analysis part. So I think there are different ways you can go with it and analyze that kind of questions.
Thank you. I can see Nikolaos Memos who would like to talk. Nikos.
Thank you very much. That was very amazing talk and amazing results. It turns that I think unsupervised, it's much better than supervised, which is a bit for the pathologist, no offense. It seems that unsupervised works better. My question, I have actually two questions. One is technical. Is the dimensions of the tile associated with the results of your algorithm? I mean, that if the tile is quite big or smaller or even smaller, might give you more information, or is it standard dimensions? This is my first question. And the question number two is whether you can predict if there is any project that a patient will respond to treatment or not. I mean, from the ones that we gave chemotherapy and they didn't do well, are there any predictors of these patients won't go well because of the pre-treatment biopsy? There are some features that could predict that these patients will not have any good results from the chemotherapy.
Okay. So just about the first comment about unsupervised being better, I think it's also depend how the question is asked. The thing is that when you do supervised, you kind of bias it with your question and with what label you want to ask. Whether when you do unsupervised, as in the case here, you kind of open the door and say, okay, I don't bias, I just don't know what morphologies will be useful, so just do it on everything. And I think that's what makes kind of made the difference in this particular case. Now for the size of the images. So definitely the field of view or the magnification which is used can have an impact. In this case, we just use like the highest magnification possible, which is 20x with 224 pixels, which is about field of views of, let me see, 100 by 100 micrometer. But the field of view and size can have an impact on the performance. So then you can analyze different type of features like different magnification, but we didn't invest it for this project. We did it for lung, but not for this one. And then for the response, so I guess technically that would be the analysis that we did for the lung, I guess, if I understood the question. So basically, it's like once you would need, of course, to train first, but once it is trained and you just give it a test patient, then it could give you some kind of plot like this one, where it will tell you, okay, the risk that there's a good or bad prognosis or good or bad survival or whatever the question is, with what are the pattern, because each HPC basically is corresponding to a histomorphology or phenotype and kind of pattern, and which ones basically are influencing the decision that it's taking, if that makes sense, if that answers the question.
Yes.
Giorgos Agrogiannis would like
Yes.
to ask a question.
Thank you, Nicholas, for your great talk. And in my opinion, each talk that includes osteosarcoma is by definition a great talk, because this tumor is very challenging, and I say it mostly for the non-experts of our company. Osteosarcoma shows high variation, not only in regards with different histotypes. We know that there is a chondroblastic one, fibroblastic, and osteoblastic osteosarcoma, but also it is very different comparing the areas in each tumor itself. I say it because I saw in your conclusions for osteosarcoma that a parameter for the worst prognosis was the necrotic cartilaginous areas. And we know by our theory and that probably, and it's very probable that these areas belong to the type of the osteosarcoma that is called chondroblastic osteosarcoma, which by definition is a very aggressive tumor because it does not respond very well to chemotherapy. On the other hand, I agree with your conclusion that osteoblastic, each osteosarcoma which shows extensive osteoblastic and fibroblastic areas shows better prognosis, because the theory says again that chondroblastic and fibroblastic variety of osteosarcoma by definition have better prognosis. What I want to say is that your conclusions are in concordance with the classical theory, and I think that if we find finally a method to quicken our paces in estimating the viable tumor or the necrotic areas, which will be very helpful in aiding to lower the time that we spend to estimate these areas. Thank you very much again.
Thanks for the feedback. Really appreciate it. Thanks.
Okay.
I don't see any other question. You can present the next speaker, Yorgos.
Okay. Since we have not any other question, it is time for the pathologist of our company. And the pathologist is a very skillful one because we're talking about Dionysi Papachristou, who is a professor of histopathology in the University of Patras. And we share the same area of expertise. Bone and soft tissue pathology is our this area, and I'm very happy when I share cases with him and I get his advice, which is very valuable for me. Dr. Papachristou is going also to talk to teach us on the use of AI in bone and soft tissue pathology and how it enhances the basis of our work. And Dionysi, the microphone is yours.
Thank you very much for the presentation, George. I'm very glad I'm here to talk about the role of AI in sarcoma pathology. Actually, I think I should be prior to the previous speaker because my talk is more basic and more practical, focuses on sarcomas. And also I will do some introduction about some definitions that many of us might not be very familiar with. So let me share my screen. So do you see my screen now?
Yes, of course.
So once more, thank you very much. So the seminar today is dedicated to the AI and the management of oncologic patients. And of course, as everybody knows, pathology has a central role. So let's see what happens in the pathology area. I will skip these slides with the very basic definitions, but I would like to stick here because AI is not something new. The concept of AI has been introduced in the 1950s by John McCarthy at Dartmouth University. But a huge step was in 1986 when Geoffrey Hinton developed the neural networks. However, at that time, the computers were not very strong. So what he said, most people feel that he was joking. Nobody took him seriously. But as the computer science evolved and the computers were more powerful, the vision that he had seems to be really true. And so in 2024, he received the Nobel Prize in physics for his work in AI. However, between this and this, many steps can be done, but most of them in the last few years because of the advancements for the computer technology. And of course, AI is considered the fourth industrial revolution after engines, electric power, electronic computers, and now it's artificial intelligence. And this is true. I will not say with this, I believe that most of us are familiar with many of these definitions. However, I will stick here to the generative AI, which is the subcategory of AI that generate new text, audios, images, video on code based on pre-trained models. So this is important because the pathology based on this kind of AI. And more, I will also talk about large language models, large multimodal models, because again, pathology will use this in order to incorporate AI in their everyday practice. We have heard about the supervised learning methods, unsupervised, etc., but I would like to give some definition about this. What is supervised learning? A supervised learning is a method used labels and annotations as input data. So this is hypothesis-driven, and as regards pathology, you use it for treatment classification, mitotic figure detection, counting, immunohistochemistry scoring, for example, PD-L1 or KI67 index, and CNN and vision transformers are part of this. The opposite is unsupervised or weakly supervised learning models where the input data is not annotated. So this is hypothesis-seeking model, which enables the discovery of novel histologic patterns of clustering, especially in rare sarcoma subtypes, and also is used for predicting mutations or any other information that could be extracted from the H&E slides. Between them, we have the semi-supervised or model-supervised learning model, which is a partly hypothesis-seeking model, and GNN, it's a classical paradigm of that. The self-supervised learning models is an emerging field, and the thing of this is that generates novel outputs based on input data, and this is very important and will be very helpful in the future as regards the diagnosis, the help in the pathology diagnosis. So, supervised learning model is hypothesis-driven. It's very extendable, it's very important. However, it requires large annotated data. PD-L1 quantification, KI67 quantification, differentiation, stratification between different categories of sarcomas is an area that this method is used. Weakly supervised or unsupervised, I told previously, is hypothesis-seeking. It's a process that discovers novel associations, which is very, very important. However, it has limited explainability, and of course, it's a black box. Nobody from us understands what happens there. Only computer scientists can have explanations. However, it's very useful, especially for mutation prediction and H&E slides. Model supervised is something between, I told you, but it's very important for spatial multiplex analysis, which is really important, especially in identifying novel biomarkers. Generative AI, it's very important because the process of this is that they can generate novel output data, which is very important. And of course, this will help in the future pathologists to make decisions as regards the diagnosis of specific tumors. Foundation models and vision foundation models are also important because pathology also uses that. So foundation models are large-scale machine learning models, often pre-trained on massive data sets, which are unlabeled. They can be adapted to a wide range of types of tasks, just like question answering, information extraction, image captioning, or object recognition. We could say that the way this model works is somehow the way we teach our residents in order to learn new things. A subcategory of foundation model is a vision foundation model, vision transformer, where it is focused on processing and understanding visually. It will outperform CNN, it outperforms CNN, but it requires large amount of data for accuracy and less training time compared to CNN. This will replace the CNN during the visual data processing and evaluation. So if we check these graphs here, you can see that the last few years there is a huge explosion of published data as regards AI and pathology. This highlights the importance of the use of AI in pathology and also the interest of the scientific community in this field. However, even general media also gives much information regarding this field. So the first important step in the incorporation of artificial intelligence in pathology was the digitization of histology slides. So this was the very first and very important step. However, nothing could be happened if we didn't have these powerful computers in order to process and to evaluate and get results from this digitization. So what is the role of AI in sarcoma pathology? Because this is my field of interest, and I think there is much room here for AI. Indeed, sarcomas are fertile ground for AI. And why is that? Because they are very rare tumors. So officially, they belong to the category of rare tumors with less than 6 cases every 100,000 population. And they are they have extreme variability. So there are too many subtypes, too many different histological appearances, and this creates many problems. So this is the latest WHO classification of soft tissue tumors, is how many tumors there are, and about 120 cases. And sorry. And this is the similar list of bone tumors, about 56 tumors, so too many subcategories. And now we expect a new classification, maybe there are many more subcategories. So a very rare tumor with many subcategories, with not many pathologists that are expert in this is a problem. So the reproducibility in the diagnosis of soft tissue sarcomas is very poor. And actually the time from the first symptom to the final diagnosis is also big. So it's about 4.3 months till 94.6 weeks, a huge amount of time that has to do with the final diagnosis. However, this is not applies only to pathology. It refers to surgeons, the radiologists, the oncologists, all the doctors that deal with that and are not well trained and expert at it. So this is a huge problem that has to do with worse overall survival, and of course the treatment it's not on time, that affects the survival of this patient. So because of the rarity of these tumors, because of the morphologic variability, and because of the fact that there are not many doctors that are experts in sarcomas, this makes the need for AI incorporation very struggling. So what are we expecting? We expect AI to improve diagnostic accuracy, to reduce inter-observer variability, to aid in grading, subtyping, and prognosis, to reduce the time for diagnosis, and to find novel biomarkers and new classifications. But are we close to that? Actually, a few years ago, there was a paper at Annals of Oncology representing the ESMO thesis on this issue. So they concluded that AI can help pathologists make faster and more accurate diagnosis, and this could substantially improve the clinical management of these patients. Another paper that was published in 2022 examined the role of artificial intelligence in improving the diagnosis accuracy of deep myxoid soft tissue lesions. So in this paper, they examined 350 slides with CNN models. And the cases included intramuscular myxoma, myxophthalmosarcoma, myxoid liposarcoma, low-grade myxosarcoma, and extracellular myxoid sarcomas, that were examined by 5 pathologists with different levels of expertise. Surprisingly, the overall accuracy was only 69.7%, and this was even lower when they examined bulk samples, which was at a level of 63.2%. However, when the CNN models were occupied, they used the DenseNet 121 and the EfficientNet B3, and they showed that the use of these networks outperformed pathologists in the diagnosis of deep myxoid tumors. And as you can see here, the accuracy was significantly better, and the ROC curves were very good in the case of the application of these models, CNN models, in the diagnosis of these tumors. The only category of tumors that the system did not work well was to differentiate between intramuscular myxoma and low-grade myxopapillosarcoma. We all know that these tumors are very, very similar. So what we need now is to add more cases in the system, the model, in the network, and in order to fed better and give more accurate results. However, the trend is there. As regards of new sarcomas, many studies have been done on rhabdomyosarcomas. So we started from Franken and al. From 2022 again, and use CNN-based models in order to differentiate two types of rhabdomyosarcoma, alveolar and embryonal, and clear cell sarcoma. Again, the results were amazing in order to separate these different tumors. The same group used heat maps in order to make diagnosis. So here is a whole slide image of alveolar sarcoma. The red dots represent the cases that are most probably the areas that most probably represent alveolar sarcoma. And as you can see here, the model was very accurate. However, in this case, this did not happen. This is an alveolar sarcoma. However, the model did not predict that well. Again, this is a problem that will be solved if more and more data enter the system. Another paper from the team of Patrick Levy explored the role of deep learning of rhabdomyosarcoma pathology images for classification and survival outcome of patients. Again, as you can see here, the results are very exciting. So this model could predict and could classify accurately rhabdomyosarcomas, alveolar and embryonal. And also the results showed that this model separated the patients into high and low risk groups, again, based on histology alone. Another paper trying to dive deeper into the molecular aspects of these tumors, tried to see how they could predict molecular subtyping and survival of rhabdomyosarcomas using deep learning on H&E images. And again, they categorize the rhabdomyosarcomas in fusion negative and fusion positive ones. And so the trained model could accurately classify rhabdomyosarcomas in a high group subtype, which is associated with PAX-T7 and FOXA01 mutations, as you know, and with an IUR at the level of 0.85. Again, these models that they used could also identify tumors with RAS pathway, MALD1 and T53 mutations, and with quite good AUR, especially for MALD1 mutations. So they concluded that CNN models were superior in predicting event-free and overall survival compared to current molecular clinical stratification. And this is very important if we think that molecular analysis are cost money and are time consuming. So maybe through this way, or if you combine these two aspects, you can have very, very good results. Another study again, soft tissue sarcomas try to separate different subcategories, again with a good sensitivity and specificity. However, as you can see in this paper, for example, more cases are needed in order to educate the system. A very recent paper, again, using AI on histological images, trying to find patterns that predict the metastatic survival in these patients. And they used again CNN. Again, the results are very, very good and give us hope for the future. This was a very nice paper by our friend Christina Mensiu from Royal Marsden, where she used city-based radiomics in order to classify different histological groups and grades of rhabdomyoperitoneal sarcomas. And they had some very interesting findings. They identified liposarcoma, the differentiated liposarcoma from liposarcoma with an IUR at about 0.92%. And they predicted a grade and with an IUR of 0.88%. So this gives me the hope that in the future, radiology and pathology will combine So we could form a big diagnostic department where, with the use of AI and the molecular and other data, could make very accurate diagnosis in sarcoma patients. Less can be done in bone tumors. As the previous speaker said, most of the research focuses on the necrosis areas after chemotherapy and how this is associated with the tumor, the prognosis of the patient. And as you can see here, among all these papers that focus on AI and sarcomas, only these three focus on osteosarcomas, and all of these focus on the identification of areas of necrosis. These are some papers that do the same thing, and they have interesting results showing that AI could very nice predict not only accurately the necrotic area, but also, as the previous speaker said, give us some very good information regarding the prognosis of these patients. A very interesting abstract that was published in last year's ASCO showed that using this model, they could separate and control from low-grade sarcoma a very, very difficult situation in bone pathology using radiograph and histopathology. So the trained model had an accuracy of 73.7%, which is really, really strong regarding the difficulty in the separation between these tumors. My group and I, with colleagues from Greece and United States, have developed a neural network that can separate osteosarcomas from benign bone lesions, just like fractures and osteoblastoma and aneurysmal bone cysts. Our model works in both post-light images, but also in classical glass slides. And this is the environment. And we showed that our model could separate osteosarcomas from fractures with accuracy of about 95%, and sensitivity and specificity are again about 95%. Of course, more data are needed in order to make our model stronger and separate osteosarcomas from benign lesions and also reactive lesions like fractures. Another huge step in the sarcoma pathology will be, in the use of AI pathology, in the AI pathology, will be to improve the scoring of existing biomarkers, but also to generate new biomarkers using the GNN networks. This is something very important. We're looking forward to it. We strongly believe that using AI and in unsupervised or semi-supervised model will help us to discover new and more reliable biomarkers. But the future pathology AI will be the visual language models. So what is this exactly? Is this that they use text and image encoders, and using that, you see here, you can see image and text encoders, and the multimodal models use not only image and text, but also genomics, and help us to make correct diagnosis and in an unsupervised way. So what happens in the future, or in the past, was that we have the specimen, again, grossing, the case distribution to the pathologist. We did our analysis through the classical microscope and send out the reporting. Somewhere here, we asked for immunochemistry, molecular fibers, NGS, and things like that. However, with the use of AI, things will change. So what will happen? This is the same, but after the scanning of slides, through after the digitization of the slides through the scanners, AI will take place, and what we'll do, it will separate the cases that will go for biomarker examination, that will go for molecular analysis, or if cases, if the slides are not good, we'll send back to have recuts and rescans. Then, if everything's okay, it will distribute to the pathologist, and the pathologist will also receive data from molecular analysis, histochemistry, from biomarkers, and then we'll stick in the computer and make a final diagnosis. And of course, the model not only will help in diagnosis, but also will help in reporting and writing the report, the pathology report. So it will improve the workflow, it will be more cost efficient, it will improve, of course, diagnostic accuracy, it will help in more personalized treatment, It will help in discovery of novel biomarkers, and of course, the system will continuously improve, but also we have the opportunity for self-improvement, which is really important. However, as the previous speakers mentioned, there are some key issues that should be addressed. For example, data variability across labs, stains, scanners, stains, all the laboratory stuff are different, so they generate different results. There's a lack of interpretability. So AI has a black box, nobody knows what exactly it is, we're afraid of that. There's bias in trained data, as the previous speakers mentioned, which is very, very important and should be addressed. Privacy and GDPR issues, regulatory uncertainty, who is responsible, how the validation is correct, integration with existing AI systems. A very important problem is that the pathology will be de-skilled. So if we use AI every day, the problem of skilling will be obvious and very clear. And of course, the high cost of deployment, scanner, storage, licenses, these are very, very expensive. And of course, not every laboratory can use it. So this may create a discrimination. How this could be addressed? Build multi-institutional diverse datasets, develop explainable and transparent AI tools, ensure legal frameworks, foster collaboration with pathologists, improve LIS and digital workflow integration, design training programs to prevent de-skilling of the pathologists, and of course, make AI tools accessible for low resource settings. So with all, I would like to thank you. Of course, I remind you that July is Sarcoma Awareness Month. And again, I would like to thank you, the organizers, for this excellent webinar.
Dr. Papachristou, thank you very much for the great talk. We did not expect something less than this. And I would like to ask the audience to see if there are any written questions in the chat. I cannot see anything. Is there anybody from our colleagues who would like to make any comment or questions? So in this case, allow me, Dionysius, please, a personal comment. And the question for you, according to your experience, do you have the feeling that among the different areas of the pathology, the different specialties, subspecialties in pathology, sarcomas will be maybe the last one who will find severe help from AI due to their complexity and due to their heterogeneity?
That's true. This is a sad truth, though, because sarcoma pathology is the pathology that really needs help. But because of the rarity of the tumors and the very, very huge variability of the histology of tumors, who will unfortunately be the last that will be have really benefits from AI. However, when this happens, I think there will be a big explosion, and the patients will really be benefit from that. But unfortunately, I don't think that this will happen in a short time. On the other hand, in the other systems, just like breast, prostate, GI, central nervous system, it seems that things are faster. They're not very complex in their histology, these types of tumors. There are many cases. Breast cancer or prostate cancer are very rare tumors. So given that they're not rare and given that their morphology is quite simple, the AI will be very helpful. And they use in some institutions, United States and Europe, they use FDA-approved models that help them in the diagnosis in everyday practice.
I have the same feelings as well. So, Dr. Memos would like to make a short summary or some general comments on these great talks that we...
Yes, of course. Professor Papachristou, amazing talk. It's good to have you on the team. And now with the AI project that you are managing, I think we can learn a lot. My one comment for your talk would be whether we could focus on some more common sarcomas, so we could have more data, less complex, like liposarcoma or leiomyosarcoma, and then we can
I agree with that, and that's why a few of the studies that have been done are focused on this type of tumor. So retroperitoneal or leiomyosarcomas or liposarcomas, because are, let's say, more common than the other ones. Another thing is that they are not very complex in their morphology, so it also helps. If we talk about sarcomas, they are very, very complex by themselves, the morphology. So yes, this kind of research and that focuses on more common sarcomas will be more helpful, and indeed several studies can be done on this aspect. And I would like to emphasize in this, combined with the first talk, that I strongly believe that the diagnostic departments, pathology, radiology, molecular analysis, should be together. AI should embrace all of them to be a diagnostic department where, using all of this information, we can reach not only correct diagnosis, but also predict prognosis, response to therapy, and every other question that the clinician needs from us.
Thank you. I totally agree with that. So let's close this session. Thank you everyone for being here. I know it's a tough time now, and we had around 45 people inside. And taking account that the Hellenic Surgical Society had simultaneously a webinar, so we get a good score, I think. Let's have nice holidays to everyone. Our next webinar will focus on vascular tumors, especially angiosarcomas, with new data coming in, and will be around October, 8th of October.
8th of October.
Yes, 8th of October. Thank you everyone for being here. I think I have been more wise from this webinar. Hope you do as well. And see you again.
Have a nice summer to everybody.
Bye to everyone. Bye.
Bye. Bye, everybody.